So this is part 3 of 3 for blood flow restriction training in the upper extremity with an emphasis on the practical applications, current concepts as of November 2024. So this video is going to pick up where the previous video left off, and that was on step 6. So you've already gone through steps 1 through 5, and then we're going to be monitoring and going through a progression when and how to progress the exercise for the upper extremity. So let's talk about some basic principles and foundational rules that should be used for best practices with blood flow restriction training to ensure the best safety and side effects are mitigated. So number 1, confirm no contraindications for normal exercise using a PAR-Q. So a participation RQ, which is usually used in the fitness setting for healthy individuals and helping to risk stratify whether they are appropriate for physical exercise without any precautions or contraindications. Additionally, video number 2 gives an extensive overview of an algorithm and screening process that can be utilized in order to risk stratify someone's potential for having an adverse response to blood flow restriction training. Second, hemodynamically unstable patients. Previous slides have were shown in part 2 of 3 that should not partake in BFR, with the exception that there may be expert clearance that is provided even in the hemodynamically unstable patient. Thrombotic disease patients, those that either have a genetic predisposition or have other risk variables that would increase their probability of having a deep vein thrombosis or pulmonary embolism would be contraindicated. Explain that there are side effects, particularly petechia and hemorrhaging, that is like the bursting of small blood vessels beneath the skin directly underneath the cuff, as well as the expectation that there's going to be pressure on the cuff. Sometimes people can get a little bit of tingling within the limb. It will likely change color. It will likely swell. These are all normal and healthy responses to blood flow restriction training that will immediately resolve upon the reperfusion and releasing the pressure. Individualized training to the subject's physical capacity and condition. This is important irrespective of whether we're talking about blood flow restriction training or not. And then finally building relationships and trust with the patient such that there's open lines of communication, that they have confidence in your care, and thus this can also ensure that there is equal opportunity for them to voice their discomfort or hesitation or questions that they may otherwise have about the modality in practical application. Okay, number 7, pay attention to prodromal symptoms, which are those symptoms that can lead to the potential syncope. Faintness, dizziness, lightheadedness. Patients often look a little bit pale. They get a little bit quiet. You want to be paying attention to these as the sets go on and the exercise duration increases, as well as the intensity. Continue to monitor your older adult and your bedridden and or post-operative patients, not only because of their hemodynamic responses, but also the increased risk of DVT that comes in the post-operative patient. Again, they're at a innate risk of increased at the probability of having a DVT, irrespective of the blood flow restriction training. The blood flow restriction training has yet to actually demonstrate that it increases one's risk of DVT, but in your postoperative patients, it's already elevated. So do keep an eye on that. And again, your risk stratification profiling that was previously presented will help with that. Making sure that you're in a safe medical environment. There should always be an AED available. This is, again, good practice irrespective of basic BFR principles, or application, I should say. Short-term and low intensity loads are ideal, particularly when first starting out. High intensity loads has little added benefit, but maybe actually rather dangerous as far as like the hemodynamic and the blood pressure responses. Particularly if it goes on for an extended duration of time. Longer duration Upper extremity greater than 15 minutes, lower extremity greater than 30 minutes. That 15 minutes is a bit conservative. You could go up to 20, particularly with like upper extremity ergometry, such as like with an arm bike, etc., would be usually okay, but then wanting to deflate thereafter. If unsure about medical conditions, make sure that you seek specialist consultation will be important, and working alongside a collaborative care team and multidisciplinary approach is going to be best ideal. Beyond that, those best guideline practices, when should you consider deflating the cuffs? Uh, so the development of ventricular or arrhythmias, again, you may not know that unless you have an EKG on them, of course, but maybe you're having a pulse ox and you could potentially identify whether there's an unsteady rhythm. A lot of the wearables these days are getting more accurate with this. Onset of chest pain or discomfort or any other symptoms suggested of myocardial ischemia. But again, I share these obviously in the context of blood flow restriction training and when you should deflate, but irrespective, you could also just flip the script and say, when should you stop exercising within the clinical setting? These all would still apply. Dizziness, confusion, deteriorating balance, or other significant neurological symptoms, paleness or cyanosis, vomiting, nausea, or feeling generally unwell. And the fact that I'm suggesting these as far as time points or indications to deflate does not suggest that this is what you would otherwise expect, or that BFR increases the risk of these things happening, but they could potentially lead to, or you want to obviously further adverse events, and so you're consistently monitoring your patients regardless of the modality that you're doing, BFR or high intensity resistance training, or really any form of intervention. Decrease in systolic blood pressure from rest, less than 10 millimeters of mercury in the absence of symptoms. Again, this is difficult if you're not ongoingly monitoring them. Systolic blood pressure greater than 250 and or diastolic less than 115. Similar for your exercise guidelines. Exhaustion or fatigue or malaise, sometimes persistent for days, that is out of keeping with the person's usual response to exercise. So feeling as though they're extremely fatigued. So for instance, I've used it in an individual that was post-operative after, and their operation and their initial injury occurred after a motor vehicle accident, and thus they had a mild TBI and post-concussion based symptoms that they were still recovering from. These were persistent in nature. It was chronic. It was several months out from the actual accident, but they were still seeking vestibular care for their the ongoing dizziness and vestibular-based symptoms that they were having. And after blood flow restriction training, they were feeling increased fatigue for an extended period of time that was unusual for them, and unusual response for the majority of people that I would see, and thus we had to desist on the blood flow restriction training for a period of time until their post-concussion symptoms gradually reduced. Swelling and shortness of breath. So swelling within the limb would be otherwise normal, but abnormal if it's like localized around a particular joint, around the particular injury. But cell swelling is a known side effect. Skin of the affected limb is too hot or too cold to the touch. Increased excessive pain in the affected limb. Excessive discoloration of the affected limb. Again, you're going to expect some discoloration, but if it's and the more that you do it, the more acclimated you will become and more sensitive you will become of what is an adverse discoloration versus not. And then obviously if the patient specifically requests to stop. So within our algorithm that we previously presented, then there's 4 possibilities. The initiation of ischemic preconditioning for blood flow restriction training, the initiation of low intensity cycling and walking, the initiation of low load resistance training with 20 to 40% of your 1 rep max, which is more your classic application, and then the more hybrid and integrative approach when you are bridging someone back to performance and fitness and return to sport, return to activity, combining low load BFR with high load traditional resistance training. And so with these 4 possibilities, you can break them up into phases. So the second phase would be using a combination of the initial low intensity BFR cycling and walking, and or if we're talking about the upper extremity, maybe you're doing your arm bike rather than your lower extremity walking. But again, there's still overall systemic benefits that can be had for someone if they're, even if you're rehabbing their upper extremity, say their postoperative rotator cuff tear or some Tommy John surgery, etc., and they at the elbow, and they are still trying to just get some form of aerobic training or maintain that aerobic fitness. Low load BFR while walking on treadmill, even though you're rehabbing the upper extremity, may still be applicable. And then eventually you'd break out of that phase once they could tolerate higher intensity loads, and you'd go to your phase 3. So for phase 1, even though this is presented as a linear progression, certainly it doesn't need to be that way. You can certainly alternate from one day to the next as far as like which of these conditions you use, be it ischemic preconditioning passively during manual therapy, ischemic preconditioning with isometrics, or isometrics with the application of NMES. The ischemic preconditioning is an area of further and upcoming research. It does show to really help to mitigate the detriments that come with immobilization, such as atrophy, bone mineral density, the reduction in neural drive from a neurological standpoint in the recruitment of motor units capacity. That being said, you want to try and be getting the person to do something active if at all possible. Even if they can't volitionally activate, using NMES, for instance, is better than just the passive application alone. So, ischemic preconditioning, the mechanisms are slightly different than that, but similar to when we're looking at the mechanisms of action that apply with the exercise, right? The exercise mechanism pathways that we've previously discussed have been mechanical transduction in nature. They've been hormonal and hypoxic in nature, and cell swelling. And so the cell swelling and the hypoxia you still get, though not nearly to the same extent that you do when you're passive versus active. That being said, here is a kind of a nice layout of the different benefits that can be had with the IPC. So the range of reported potential triggers and subsequent responses contribute to ergogenic benefits of IPC. The arrows indicate the direction of documented changes within the literature. You have a decrease in muscle damage following exercise and an increase in recovery. That is, so the classic study, an initial study that was done where the individuals did a significantly high number of body weight box drops and jumps, and then applying BFR to a certain percentage of the cohort, or the BFR allocated cohort individuals. It showed a significant reduction in the creatine kinase, that is a marker of muscle breakdown, not only acutely but the next day, was significantly less in the individuals that applied the cuff after that high intensity training. The preservation of lean tissue during immobilization has also been demonstrated with IPC, and improvements in maximal performance in specifically high-level trained swimmers. Specifically, they were able to improve their swim times by 0.7 seconds, which can take, in the elite individual swimmer, that can take up to 12 to 18 months worth of training. And the fact that you can get that in an acute setting, or after the application of remote ischemic preconditioning, that means the application of the blood flow restriction at some body region with an intent of inducing improved benefits elsewhere, is the differentiating factor between the terminology of ischemic preconditioning versus remote ischemic preconditioning. And you can kind of see the 3 predominant pathways here of hormonal, neural, and the systemic, and the different subsystems that it works on. For the cardiovascular system, both central and peripheral adaptations can be seen. Metabolically, you can have a equivocal improvement in blood lactate buffering as well as VO2. And then the nervous system, you're going to get increased EMG, decrease in motor unit threshold, increased fatigue, and afferent discharge, all of which lead to the improved muscle performance alongside the other adaptations that are shown here. So if we're looking at the different applications of BFR in this first phase, our progression criteria to going to the next phase is no adverse reactions with the initiation of BFR. They're able to complete all sets and the rating of perceived exertion with that phase 1 activity is equal to or less than 7 out of 10, meaning it's getting easier for them. They're able to perform active exercises. Your goals with your ischemic preconditioning are to acclimate the patient to BFR, preserve muscle mass, i.e. decrease the disuse atrophy, begin capillary growth, and then your frequency here is up to 2 times a day. So high frequency on a daily basis. Ideally, it's been described on at least a minimum of 5 to 6 times per week, up to 7. Your limb occlusion pressure is going to be 100%. You're going to do 5 by 5, so 5 rounds of 5 minutes where they're just passively sitting there under occlusion. So the whole thing is going to take approximately 25 minutes, a little bit longer because you're going to have 3-minute rest periods within that where you're going to do a complete deflate. During those 3 minutes, it provides a therapeutic opportunity to do soft tissue work and or passive range of motion. Other interventions can be interleaved with your BFR. If we're looking at the application of ischemic preconditioning with isometrics, so again, if they're going to be active, you may consider reducing the intensity of the pressure back down to your traditional of 40 to 50 for the upper extremity and 60 to 80 in the lower. Your goals are to preserve muscle, improve muscle inhibition and increase motor unit recruitment, reestablish motor unit coordination, decrease co-contractions, a large stimulus to inhibit myostatin, which is one of the pathways that causes the significant reduction in loss of muscle mass, as well as an increase in muscle fibrosis post-operatively or in the immobilized limb. And then increase in lactate to stimulate growth hormone production to aid in collagen synthesis for soft tissue healing. You're going to do this 1 to 2 times per day, again, similar to that of the IPC protocol. The duration of time, depending on, the prescription is going to be dependent upon like what you're trying to adapt. So longer duration for connective tissue versus shorter duration for muscle tissue in regards to your set and rep scheme. And that's specifically to like the duration of isometrics that you're applying. So connective tissue is going to respond better to your isometrics at longer durations versus shorter durations for your muscle tissue. Though they're not obviously completely disconnected, and certainly the muscle tissue will still benefit from 30-second isometrics, but if you're looking at this across a continuum scale, the connective tissue, that is the tendons and ligaments, may respond better to the longer duration isometrics due to the stress relaxation that occurs within a tendon or a dysfunctional tendon that which has a tendinopathy or sorts, and or has undergone reconstruction or repair. All right, and then your dosage is number of exercises 1 to 3. Intensity is clinician and patient dependent, so use your clinical judgment based off the person in front of you. Deflate 1 minute in between your exercises, and your isometric typing, right? So it could be yielding, where they do like a submaximal, or it could be overcoming, which would be a higher intensity and a progression where they're pushing against an immovable object or pulling against an immovable object, depending on what the exercise is, whether they're pushing, pulling, etc. And then the progression criteria for phase 1 remains the same. Similar for your NMES, the goals remain the same as with the isometrics. The difference here is that your prescription is going to be different, right? So the individual is not going to be volitionally active, so you can bump the pressure higher than you were with your passive cell swelling with the isometrics. Again, it shows the limb pressures comparable to that of the individual is active, but this has also been described with the IPC protocol of 100% or 80 to 100% LOP, regardless of upper or lower extremity. Your frequency for your NMES is shown there in order to help to induce the muscle adaptation that are specific to the goals listed. So if they can do the following: no adverse reactions to initiation, able to complete all sets and reps, their RPE is dropping, and they're able to participate more readily in active exercise, well then these two. BFR, low intensity cardiovascular conditioning, may be a great place to start, and then eventually adding more resistance, or introducing resistance, I should say. This could be in the form of just body weight or internal loads before you apply external loads. You're trying to not go for optimization initially. You're really just trying to induce an orientation to resistance training with BFR in the first couple sessions, and then you can get more to your optimization of principles as far as exercise prescription. So similar to phase one, if we just step through, the goals here are going to be similar, but the fact that we're doing cardiovascular conditioning, then you're going to have an increase in heart rate, peripheral tissue neovascularization, and metabolic function, or that is on the cellular as well as mitochondrial levels, and then are going to be a little bit more of your focus, and then you're going to have an increase in lactate threshold training to improve one's VO2 max. Your frequency can be pretty high here, 2 to 5 times per week. You're going to use your classic limb occlusion pressures. Your duration should be 5 to 20 minutes, and the intensity should be 6 to 7 out of 10. Progress watts and METs as tolerated. So that's usually how I'll determine someone's workload will be in the form, like for instance, if they're on a stationary bike or arm bike, you're going to be looking at your watts, your power output is going to be determined by their revolutions per minute as well as the resistance on the wheel. And then METs is another way that you could do it if you can calculate that. If, for instance, that's more appropriate for treadmill walking. If you're going to apply low load resistance training, it's going to be similar but slightly different. It's going to be in regards to your goals, it's going to be similar to the lower intensity cardiovascular conditioning, as well as you can see some of the goals and desired adaptations coming in from phase one when they started to do their isometrics. So the prescription here from an exercise parameter standpoint, frequency and the pressures will remain the same as to that of the low intensity cardiovascular conditioning, but your number of exercises can be anywhere between, as little as 1, but typically around 3 to 5. Your duration per exercise of occlusion is going to last anywhere between 8 and 20 minutes. Typically, the longer duration exercises here are going to be because they're doing unilateral or where they're doing one limb and then the other. If you're doing bilateral BFR, or perhaps you're doing one leg BFR, the other one high load resistance training to get a cross education effect as far as the strength benefits. That can be certainly beneficial for the adaptations to overcome muscle arthrogenic inhibition. And then your sets and rep scheme, you're going to do first set of 30, which is a high bolus to create a hypoxic environment, burn out some of the metabolites that are resting within the limb, and then you have 15 repetitions for sets 2 through 4. Your tempo here is going to be about 6 seconds per repetition, so it will be 2 seconds down, 1 second pause, 2 seconds up, 1 second pause. And then your intensity is going to be 20 to 40% of your 1 RM. You could also, if you're haven't calculated their 1RM, which you could certainly do relatively easily by some maximal predictive 1RM test. Whether you use their involved limb or the uninvolved limb potentially would be would be one pragmatic effect if their limb, obviously their affected limb simply just couldn't tolerate the some maximal testing even. But you can also go off rating of perceived exertion, right? So you want them working pretty hard. You want them rating their exertion around 7 out of 10 at the end of their third and fourth set. You want about less than 2 reps in reserve. You really want to try and bring them up to fatigue with each of the 4 sets. Progression is really important and something that has become more readily described within the BFR literature, and a lot of researchers and clinicians are using the 2x2 rule. So that is, if you can, they will actually, instead of going to 15 repetitions on the last set or the last 2 sets, they will go with a failure. And if an individual can accomplish more than 75 reps, specifically if they can exceed that target rep of 15 by 2, then there should be an increase in resistance. In the upper extremity, it can be as little as 1 pound has been described, and you'll just consistently get an incremental progressive overload over time within the BFR protocol. That being said, the ACSM guidelines also recommend an increase as a percentage of the weight. You could do that as well. Either one, as long as you're trying to increase the progressive resistance over time. Also understanding that the purpose of the progressive resistance is obviously the importance of fending off habituation of the body's response to the exercise. But we're really not, our primary means of promoting adaptation is not via mechanical stimulus, it's by inducing metabolic fatigue. So we don't have to titrate or pull that spectrum or that variable of intensity and or external load as the primary. Some pro tips for this particular phase and this sub phase is making sure that they're going through full range of motion. Emphasize a control on the eccentric. Oftentimes patients will underload their eccentric and or rapidly go through it. There's actually significant benefits that can be gained by having them authentically be challenged through their eccentric and volitionally trying to contract the muscle. Additionally, across the entirety of the set, you want them to do what I call continuous tension sets. You want them to maximally be contracting their muscle throughout the repetition. I give the example of trying to be a bodybuilder on stage where you're constantly trying to get that, never giving the muscle an opportunity to relax. If you're using a manual pump, that's often common with a direct-to-consumer rather than the industrial-based units, then you want to reinflate after set number 2, because oftentimes with the contraction and the relaxation of the muscle during the active exercise is that you can lose pressure. Okay, and then within that same sub phase of the low load resistance training is that you can actually have a nice progression across the types of exercises that you're prescribing. Open kinetic chain usually being single joint and or single muscle targeted more so than your multi-joint closed kinetic chain exercises, right? In the upper extremity, you're thinking of your bicep or flexion or your elbow flexion, your bicep curl, or your elbow extension, your triceps, wrist, etc., versus your closed kinetic chain. Maybe you're having them do an inverted TRX pull-up or inverted row, one of the two, or push-up, for instance, which is more multi-joint and closed kinetic chain, where they're just going to induce a lot more muscle activity. And so starting with your lower demanding exercise, gradually increasing not only with the combined aerobic as well as resistance training and the implementation of NMES, but then gradually progressing to a larger application of different exercise selection using both open kinetic chain, closed kinetic chain, as well as aerobic exercise, really gives a more comprehensive training bolus and bout than would be any one of those combinations independent of the others. And then your phase 3 is you're going to be doing your low load BFR intensity with your cardiovascular conditioning. So you're going to kind of, you can potentially increase the intensity a little bit, or you can use the hybrid model where you're going back and forth across either a training block or within a given week between your low load and your higher intensity cardiovascular conditioning or energy system training, whichever you prefer as far as nomenclature. And then same thing with the BFR low load resistance training. You're integrating this into your traditional resistance training. Particularly, I'm leaving it for for exercises that are still either symptomatic for the individual where they can't load adequately, but they may be able to load more traditionally. That is 70% of their 1RM or higher on certain exercises due to the mechanical healing properties and tolerance or capacity of their limb and their healing tissues. I would, as I alluded to throughout some of that prescription, that it could be beneficial using the RPE scale rather than the actual 1RM percentage, but certainly the progressive overload, regardless of which one you hold them to, is going to be important, such that you're progressing the resistance and or intensity or volume of the exercise over time. Whether this is like the Omni RPE scale, whether you're using weights and or TheraBand, it's been validated in both applications of external load. Here's a correlation between someone's RPE and their repetitions in reserve. So typically, if they're at that greater than 7 out of 10, then they're having less than two or less repetitions in reserve. I really do like the 2x2 rule and encouraging the folks to go to failure and push past that 15th repetition on set number 3 and or 4 to determine their readiness for progression. And then based upon the actual RPE that they give, you can assign a potential increase in their resistance. Right, so if they're close to a 9 or a 10 out of 10, and that's just a lot for them, you could always decrease by anywhere between 5 and 6%, or 8 to 6%, and so on and so forth. So that I kind of like that progression there from Helms, but oftentimes I'm trying to encourage them to increase the load a little bit higher to ensure that they're at that Goldilocks around an 8 or a 9. And there's the 2x2 rule, kind of just spelled out for you. If the patient exceeds the target rep by 2 reps on their final set on 2 consecutive exercise bouts, then you want to progress your resistance. This is directly from the Essentials of Strength and Conditioning from the National Association of Strength and Conditioning, or NSCA. And then for your resistance band, if that's what you're using rather than your traditional weight, as the TheraBand is more often a little bit more common within within rehabilitation settings, then this would be a means of how you could determine the pounds of force of resistance based off what they're doing. And I see this obviously quite commonly in shoulder applications and upper extremities. And this just kind of is another chart that kind of helped to get the cross talk between the different means of number of repetitions performed, their percent of 1RM, and then the multiply the weight lifted by X amount in order to determine their 1 rep max. Okay, so what can you expect from someone's RPE with BFR? So this study, I kind of like it from a practical application standpoint, and I'll educate patients on this, is that with high intensity resistance training, and I use the example of like a spin class or a boot camp, if the patient had ever taken that, it's going to be kind of comparable to that with your BFR training the first time. You're going to be great, right around an 8 out of 10. And that's going to be session number 1, and session number 2 may feel just as hard, but you're going to acclimate to this. It's going to get easier. The first cut is the deepest, so on and so forth. But progressively over about 5 sessions, you're going to find this to be a little bit easier. And that's, around session 4, maybe session 3, depending on where they're at, is where you're going to try and gradually progress some exercise variable to up the intensity such that you don't get diminishing returns on your adaptations. And the examples that are shown here, just for clarification of defining the high intensity and BFR groups, you can see that they used classic parameters of 85% 1RM for the high intensity, 20% for 1RM for the lower extremity, and that was 20%, and that was for their leg extension. And the conclusions that BFR induced a marked RPE to training versus high intensity training may not limit the application of BFR to highly motivated individuals, as it gradually does induce a habituation over time. So clinical outcomes that have been described in the research setting and that may be friendly for your setting as well to determine the efficacy and the effectiveness of your a given patient or across multiple patients. Looking at circumference or thickness of the limb, though that's an indirect measurement, we know that the DEXA, diagnostic ultrasound, and or MRIs are going to be your gold standard here. Looking at force production for a muscle standpoint, using a 1 repetition maximum or a predicted 1 rep max would be ideal, or you could certainly just look at the amount of force or strength they're using with a given exercise, though that's more of a field-based and not as rigorous of a test. Work capacity using total work via fatigue assessments. So that has also been described in the upper extremity, where they will do number of repetitions to fatigue pre and post multiple week training session with blood flow restriction training, and they look at their work capacity of these individuals both in a occluded state and unoccluded state, and consistently the BFR group will outdo the control group, regardless of whether you're looking at the work capacity or number of repetitions to fatigue in an occluded or unoccluded state. Other muscle performance measures, so for instance muscle power via rate of force development using an isometric setup, can certainly show value, and we know that this is an ongoing area of expansion and research, not only in the lower extremity but also in the upper extremity. I know that Lori Mishner out of USC has looked at this as a predictive variable for individuals with subacromial impingement syndrome and identifying them at baseline. What is their rate of force development, and those that are below the norm by a certain percentage it's a risk factor for them to be non-responders to the traditional route of rehab. Using biofeedback and surface EMG can certainly help to facilitate and determine the intensity and the work capacity of at any given one exercise at a particular intensity or load. We would want to see over time, or we expect over time, that the patient would otherwise habituate such that at a given intensity for a given exercise that their EMG should gradually diminish over time, and then we would want to increase the resistance or manipulate some exercise variable to make sure that it was still challenging. Serial imaging, be it not only from tissue healing standpoint, but also, as I was mentioning, from the circumference measurement and the tissue adaptations would be of consideration. Specific physical performance measures, be that your, for instance, like your pegboard in the upper extremity or other upper extremity physical performance tests, seated shot put, push and pull ratios of the internal and external rotators, and then functional outcome measures, which are intended here to be patient reported. Within this presentation, as well as the others presented in part 1 and part 2, I've talked a lot about the benefits of BFR. Let's talk about some of the limitations. So blood flow restriction training to date has not shown to be superior in heavy load resistance training, at least in certain parameters. We also know that it produces or offers unique training adaptations compared to high load resistance training, particularly in the number and the augmentation of stem cell proliferation, as well as the gene expression. So what we're doing on an epigenetic level is comparable to that of heavy load resistance training, but it does not replace that. In fact, as I have alluded to across this presentation and the ones preceding it, that a hybrid approach, a combination of both heavy load and low load resistance training and or aerobic training is probably the best of both worlds rather than any one approach, even though we do like to know what is the best one and putting things head to head. The use of non-FDA regulated cuffs is something that needs to be archived and a thing of the future. It's a bit archaic as far as like where the state of the literature and the science is. Poor prescription practices of BFR is a limitation. Particularly, I gave examples of either underloading or overloading, as well as the lack of progression across a given exercise regimen. The effects of chronic BFR, right? It's relatively new as far as its ubiquitous use, even though Katsu training has been around since the 1950s. With the practical and the more current concepts and methodology, where they've done it for an extended period of time in a much more structured and regimented way, we don't necessarily know what the long-term implications potentially could be. All to date, the short term, we'll call it 3 months or longer, or within that 3 to 6 months, have all shown to be beneficial. But if someone uses this chronically for 30 years, that information is still unknown. Methodology of the current study design. So in the early 2000s, from like I'd call it 2000 to 2015, there was a lot of heterogeneity and risk of bias and poor quality methodology that was utilized, which is common when something is more in the exploratory state, but the higher quality studies are coming out more and more on a yearly and even monthly basis now. And so I do expect that to change, but some of the early study methodology and the size of those studies is also of limitation. So as I was alluding to, the cuff selection is a limitation. So what is unacceptable is this. Right, so you get all the marketing. If you type it into Amazon or Google browser, right, you're going to get a wide variety of non-regulated cuffs that, one, they're borderline unsafe at worst, and certainly they may not even potentially be effective, as we know the importance that exists within the creation of the hypoxic environment, and that the pressures that are utilized need to be specific not only to the individual but specific to the limb even, and there's no way to regulate the amount of pressure that is being applied to these limbs with these cuffs. So that's kind of a no-go. The ones that are endorsed, as I alluded to earlier in part 2, would be the industrial unit, specifically the one that's put out by Delphi or Owens Recovery Science, or an FDA-approved cuff such as that of Smart Cuffs. But when you look at least as of 2018, the poor prescription that was utilized for determining pressures, right? So you had a questionnaire survey with 250 respondents, and you can see it's kind of all over the board for what was determination for limb occlusion pressure. So only 11% of the individuals that responded, or professionals that responded here, were using limb occlusion pressure. The other 89% or so were using a variety of different methods, not only literature values, limb circumference, or patient brachial blood pressures. Though these are reasonable variables, particularly the limb circumference and the brachial pressures, those two, either one of those variables independently does not adequately predict what pressure should be utilized. What is encouraging is that things are changing. So here you on the y-axis you have the number of publications, and then you have the year of publication running across the x-axis, and you have the means by which occlusion pressure was determined. The blue one being arbitrary pressures, perceived tightness in yellow, systolic blood pressure. But what you do want to see is the orange bar. So as of 2008 was the first initiation of this with one publication, and then this has gradually grown to become more and more the norm, all the way up to the publication, at least of this current study that published this result as of 2018. And we expect that this is to become really more the standard of care over time. So what variables actually determine limb circumference? So for any given limb circumference, the tourniquet pressure required to stop an arterial blood flow decreases as the width of the cuff increases. Thus, the width of the cuff matters. Someone's limb occlusion pressure is specific to a brand of cuff. You can't use one limb occlusion pressure across one product versus the next. The additional variables that influence the cuff, the necessary pressure beyond just the width of the cuff, is going to be systolic blood pressure, body position of the individual at the time of taking the pressures, the sex and race of the individual, the limb density in regards to body adiposity, as well as the bone. How much of the limb is made up of bone versus muscle mass, and even the laterality, left versus right, dominant versus non-dominant, has shown to fluctuate or have influence on what the limb occlusion pressure is. And so the image there just looks at the limb occlusion pressure in millimeters of mercury on the y-axis, and then the ratio of cuff width to circumference. And you can see that there is a predictable equation that someone's limb occlusion pressure is dependent upon limb circumference as well as the width of cuff. So why does it matter? So it matters because of this. So I give you three examples: the modern pneumatic tourniquet, the non-surgical non-pneumatic tourniquet, and then the non-surgical non-pneumatic elastic ring. And what you're looking at on the y-axis for each of the figures shown is that the applied pressure in millimeters of mercury, and then the max pressure that occurs depending on the cuff width for each of the different scenarios. And what you can see is that the gradient significantly increases with the narrow cuffs that are shown with the non-surgical non-pneumatic tourniquet, that is more of an elastic ring, or even a nylon strap, both of which have millimeters of mercury that are upwards of 450 millimeters of mercury in pressure. The higher that goes, the more likely the risk of injury is to nerve and other sensitive structures that directly underlie the cuff. So the ideal is to find that Goldilocks amount of width of a cuff such that you don't have to use excessive pressures, yet you're also not essentially blunting the tissue adaptation or the amount of tissues that would otherwise adapt to the actual cuff itself. Each of the tourniquets was selected and applied as recommended by the respective manufacturer to stop arterial blood flow in the upper extremity. Higher levels of pressure and higher pressure gradients are associated with higher probabilities based off patient injuries, as I was alluding to. And then the risk of nerve-related injuries increase with pressure gradients. Higher demanding pressures are associated with not only the nerve-related injuries, as I was alluding to, but also the high cardiovascular demand, as the pressurized response and the pressor response that comes from the amount of peripheral nerves that are innervating the muscle under occlusion, and then a complete arterial flow decreases the effectiveness of BFR, which potentially those other cuffs that are elastic in nature and are non-pneumatic, and it's hard to determine the interface pressures, potentially could do. So the slide taken from part 2 of the presentation, the things that you want to look for within your cuff selection is you're going to be doing FDA registered cuffs, that is cover your ass, pneumatic tourniquets, single chamber, circumference bladder, and curved cuffs are going to be best suited for proper application and safety application. And then auto regulation is a nice to have, but not a necessity. And the auto regulatory feature is that which maintains the pressure during the exercise with contraction and relaxation. Along the same lines of poor prescription. So again, out of that same survey of USUDA in 2017, we can see that a lot of respondents were keeping the occlusion pressure at much too long durations, which is, again, the longer duration of occlusion, depending obviously on the intensity, the increased risk for adverse responses, as well as the blunting of the documented adaptations that have previously been described. And then, as previously described, the effects of chronic BFR are still unknown, and the utilization will be determined in time. And the methodology of the early studies is somewhat in question. Small studies, higher risk of bias, the methodology and the structure of them not as rigorous as we would otherwise hope, but the more recent studies in the last 5 years, as of today, 2024, has significantly improved as we've really started to refine what the optimal parameters should otherwise be. And then the final thoughts on legislation and logistics. Scope of practice. So according to the APTA, though I'm not completely aware of what the American Occupational Therapy or Hand Association has otherwise come out with, but to my understanding that it is also within the scope of practice of other therapists and therapies as well. The scope of practice of a physical therapist has 3 components. It's professional, which is governed by the APTA, the jurisdiction or legal, which is governed by the state's practice, and then the personal, which is the consistence of activities for which the individual or physical therapist is educated and trained and with their competencies to perform. And so that really kind of falls on you, whether you know that you don't have to be certified necessarily. I think that it's good certainly to be educated. BFR became part of the OT and PT scope of practice as of 2018 based off my research, and CEU credit is available for all licensed medical providers, including ATCs. Licensed medical healthcare providers are able to purchase medical grade pneumatic tourniquets, such as the Delphi unit with any one of the following licensures. BFR is part of the professional scope of practice of physical therapists as described by the positional paper by the APTA, as well as the AOPTA or AOTA. And then the state legislation, check the State's Practice Act, may be silent in regards to BFR rather than actually specifically stating or calling it out by name. As far as the California Practice Act though it doesn't mention it specifically, there's no laws prohibiting the use of an application of it. Okay, then if we're considering FDA regulation and pneumatic tourniquets, they are considered a class 1 under the FDA and are regulated products. Thus, it's important and essential to ensure that the product and or cuff that you're using for quote-unquote BFR is registered and approved by the FDA when practicing within the United States. Thus, further giving an example previously that a TheraBand may potentially leave you open to lawsuit if you're practicing in the U.S. So it's best to spend the money and ensure safety within the clinical setting. All right, so billing, so it's obviously billed under the standard physical therapy codes depending on the activity that you are performing with that said patient. Thus, if you're doing BFR and NMES, then it would be potentially neuro-re-ed
unless you're really concerning that you're strengthening the muscle at that time point. But therapeutic activity, whether you're doing a manual technique with it, what have you, again, it's billed under the traditional therapy.
All right, and then summary and conclusion. So in part 2, we presented the flow chart here as far as risk stratification and decision making for when your patient is otherwise appropriate. We spoke about that you're asking the question, can they actually benefit or should they benefit from this? What are their contraindications with the electronic medical record and subjective screening? Getting the patient and the physician's consent, controlling your effusion and inflammation, treat and control that first, then perform your LOP, and then determine your appropriate type of exercise and apply it effectively given the parameters and the progressions that have been described in this part 3. We spoke about the exercise specifications for the different variables, the type of exercise, the frequency, intensity, volume, rest, and duration, regarding whether you're going to be doing passive exercise, aerobic, or resistance exercise. Each of these variables may be manipulated accordingly to be optimal for inducing the appropriate effectiveness of the adaptations that are always desirable for your blood flow restriction training. You have the volume of the 5x5 for your passive with a higher frequency, up to twice a day for 5 to 6 days out of the week, whereas your aerobic and your resistance is usually done closer to 3 to 4. The parameters in regards to the exercise intensity is mild to moderate, both aerobic and resistance based. The duration of occlusion is going to be comparable regardless of whether you're doing aerobic or resistance, with a bias towards slightly longer with your aerobic just due to the reduced fatigue that is associated with that. And then your duration of time, your duration of training protocols or programming should be a minimum of 6 weeks, though we also spoke about the fact that this is a bridge to the tolerance to higher load traditional resistance training that can have its own adaptations associated with it. So phase 1, phase 2, and phase 3 if we're sticking with the progression that is otherwise offered. And then looking back at the objectives that we had set out for the part 2 and then bleeding over here into part 3. What is blood flow restriction training? How does it actually produce the said adaptations? So going deep into the mechanisms on a cellular and even a genetic level. Why would I consider using BFR and who could benefit? We've talked about that. And what does the evidence say about the effectiveness of BFR? This was in part 1 predominantly. How do I safely apply BFR was the focus of part 2 of 3. And we had our sub questions of, is it truly safe and for who, and what are the risks and side effects? And then the clinical application was a combination of both part 2 and part 3. I hope this was beneficial. Feel free to leave your comments, questions, and feedback in the discussion sections below. Here are to follow will be the references.
Flip through the slides.